Yesterday I spoke about stem cell transplantation. Today I'm going to put on the leukemia chemotherapy hat, and I am going to talk a bit about the USA, but we've heard a lot about hyper-CVAD already and the USC experience, so I'm going to put a bit of a focus on the UCSF experience over the past several decades. You've seen this graph in a number of slides yesterday and today. Archie Blyer showed it. It shows the SEER data for survival based on age, and basically talked about the join points at age 16 and 21 where there's a sharp drop-off. What I'm going to be dealing with is the lower part of the curve in adults predominantly, an area that is predominantly taken up by the hyper-CVAD space. But there's more than hyper-CVAD out there, and we have our version. Now, if we accept this cartoon as the basic structure of augmentin BFM backbone, my intention on this was to demonstrate that myelosuppressive modules are rectangular, non-myelosuppressive modules are circular, and the anvil represents maintenance. If you take a look at UCSF Protocol 8707, also known as the linker regimen, it has a very different look to it. So we have twice as many myelosuppressive modules. We do have other non-myelosuppressive as well, and maintenance. And so the design in the adult trials tends to be a little bit more myelosuppressive heavy and a little less on the lighter side for non-myelosuppressive therapy. I showed this yesterday, sort of the UCSF version of risk-adapted treatment in adults with ALL, taking the poor risk individuals with the intention to allogeneic transplant in first remission, but treating the favorables and the intermediates with adult chemotherapy, and the UCSF therapy is what we generally use. Now, if you look at NCCN guidelines, I showed you yesterday the guidelines for the AYA group. Here's the guidelines for recommended regimens if you're 40 years or older. This includes CLGB 8011, the Larson regimen, our regimen known as the linker regimen, hyper-CVAD, and then the United Kingdom 12 ECOG 2993 regimen. So what's the history of ALL therapy in adults at UCSF? It began in 1980. Dr. Linker put together Protocol 8001, a 4-drug induction regimen including L-asparaginase. That was 12 doses of L-asparaginase and had a complete remission rate of 88%. And you have to think backwards to know this was really sort of the infancy of using asparaginase in adults. There were then 9 consolidation phases, 8 of which were myelosuppressive. And so it was a watered-down version of induction, followed by teniposide and intermediate dose cytarabine, and then this was repeated for a total of 8 cycles. And then it was culminated in a single high-dose methotrexate module. That regimen involved cranial radiation for CNS prophylaxis, 6 doses of intrathecal methotrexate, and unlike the typical POMP maintenance, we only use 6 MP in methotrexate. And I'll point out there were a total, therefore, of 5 courses of asparaginase in this regimen. Here are the results that were initially published in Blood, and this is the update as of year 2007. Of those entering remission, a third were cured. And there's a very good stability to the plateau, as you can see. In 1987, and Dr. Linker and myself put together how can we make improvements on this regimen. So for our induction phase, we increased the dose of daunorubicin. For the alternating phases, we greatly increased cytarabine from 300 per meter squared to 2,000 per meter squared for 4 doses. We switched from teniposide and went to etoposide at 500 per meter squared daily for 4 doses, so very marrow-suppressive. These are called the B cycles. And then we gave much more and earlier high-dose methotrexate, going from essentially 700 per meter squared to 3 gram per meter squared for 6 rounds, called the C cycles. Now, because this was so heavy at high-dose cytarabine and high-dose methotrexate, one of our objectives was to see if we could safely eliminate cranial radiation as CNS prophylaxis. So we only kept the intrathecal methotrexate as the prophylaxis and continued our 2-drug maintenance. I I didn't really think about this much until recently. I was preparing for this talk, but that dropped us from Protocol 8001 from 5 courses of asparaginase to only 2 courses of asparaginase. I'm sure we talked about it back then, but I guess it just never sunk in that we had really made that dip in the asparaginase intensity. So it looks like this: 1A, 1B, 1C, 2A, 2B, 2C, 3C, and maintenance. So I'll echo what Dr. Jabbar said yesterday. One nice thing about it, if there are any nice things about it, is you can remember it. And it's not a very complicated protocol, but it is what it is, and it's heavy in myelosuppression. So this is just comparing the 8001 results to the 8707 results. The complete remission, as typical now, above 90%. For all individuals, the leukemia-free survival improved from 36% to 52%. For the B lineage individuals who did not have poor features, we doubled from 34% to 66%, looking like a marked improvement. For those with poor features, we didn't help anybody. And I made this point yesterday when I was talking about our autologous transplant regimen. For these individuals, if we could not find a donor for allogeneic transplant, we would begin taking them to auto-transplant and had a 43% long-term leukemia-free survival in that group. I already showed that. Went backwards, sorry. So here's the results in terms of the event-free survival curves, published in 2002 but updated in 2007. At 10 years, our event-free survival of all patients, 52%, and out to 20 years, 48%. If we break it out by the risk groups, the non-poor individuals versus the poor-risk individuals without a donor, this is looking quite good with a 10-year event-free survival of 60%, and everyone in this group has died by 9 months into their treatment. So that's the group that we targeted for autologous transplant if we couldn't find them a donor. Matt Wiedewelt pointed this out this morning in his talk. We've put together a University of California hematologic malignancy consortium in which our sentinel trial to try to do as a group is the new version of UCSF 8707, and we're calling it, I guess, the California trial. And in this particular circumstance, we have to put PEG-asparaginase in as L-asparaginase is absent, and it's going to be 2,000 units per meter squared for 6 courses. So we've gone now from 5 courses to 2 courses back to 6. This is a mistake. We initially talked about using dexamethasone, but after more conversation and more data, have decided to stick with prednisone when we're using it as our corticosteroid chemotherapy. We're going to incorporate for B lineage individuals rituximab, for the most part after corticosteroids, and Matt did outline that there'll be a randomization for 4 of the 6 PEG-asparaginase, that's later. I meant to say it up here. Before 4 of the 6 PEG-asparaginase administrations, there'll be a randomization, hydrocortisone versus placebo, to see if we can reduce sensitization. In the rituximab, we're going to do this, and we're doing it regardless of whether there's CD20 expression in the B cells. And the reason for this is that being able to quantitate that there's CD20 positivity may have nothing to do with the biology of using rituximab, but also data in pediatrics that if you have corticosteroids to CD20 negative lymphoblasts, there can be upregulation and expression of CD20. So all B lineage, we're going to give rituximab. Our CNS prophylaxis will switch. We're going to use liposomal cytarabine for 8 doses. We've learned from other investigators not to give it during high-dose cytarabine modules. Decide to take a more traditional maintenance with POMP and incorporating 4 doses rituximab and B lineage. So the schedule change compared to 8707 is now 1A, 1C, B, A, C, B, C maintenance. And the reason for this is we wanted to give 2 full months of asparagine depletion, so we're using the PEG-asparaginase with the anthracycline after there's neutrophil recovery, and we're also using it with the high-dose methotrexate module and avoiding the high-dose cytarabine for lack of safety. efficacy. So that's sort of where we're at with the UCSF-based versions. To look at the others regimens recommended by NCCN, I have these definitions. I'm not sure they're standard or not, but for the purposes of my next slide, I put these in so you understand what I mean. And if we look at the 4 regimens, compare and contrast a bit, obviously their designs are quite different, as you can see. We're very heavy in high-dose methotrexate in the 8707 protocol. Hyper-CVAD has 8 myelosuppressive consolidations. In all fairness, mixed in with that is high-dose methotrexate as well. And this is the United Kingdom ECOG protocol. A couple things that are different. 2 of the protocols had utilized cranial radiation as CNS prophylaxis, CLGB 8811, as well as the United Kingdom 2993. And then other comments, 2 courses of asparaginase here, 2 courses of asparaginase, 1 course of asparaginase, 1 course of asparaginase. And I've mentioned that POMP is typically used, except we did not do that in our particular study. When you look at the age of the individuals who are enrolled in these studies, usually it's in the AYA group as the lower bound, so 16, 16, 13, and 15. Then some, like CLGB 811, went up to age 80, as did modified hyper-CVAD. Ours went up to age 59, and the median ages are shown here. Although I couldn't find the median age here, surprisingly, in the chemotherapy patients on that study. The sizes are roughly the same in terms of the accrual number, except ours, which was the smallest. I do note in the CLGB 8811 and in the linker protocol, there was Philadelphia positive patients involved. In CLGB 8811, it was 13% that were known to be Philadelphia positive. In our study, it was 16%. But a huge proportion were unknown at that time. So at that time, the use of routine cytogenetics and other things was just coming into practice, and so there were a lot of unknowns about how much Philadelphia chromosome individuals were really in these trials. Both the modified hyper-CVAD and the United Kingdom ECOG study, they deliberately knew what those were and excluded Philadelphia patients, so they're 0. If you look at the 5-year leukemia-free survivals, they're roughly about the same, 45, 52%, upwards of 56%, depending on which version of the modification is used. 41%. And the overall survivals are very similar as well. 3 of the studies reported the outcomes in 5-year over survival under age 60, 60%, 63%, 76%. We do know that is true, that the younger patients will do better. I guess one of the questions is it still better to do these individuals on a pediatric-based regimen? I think the general answer is people have accepted yes. But the outcomes are shown here, not reported in the other that I could find. You did see this curve just using rituximab. This is in individuals at MD Anderson on the modified hyper-CVAD protocol who were CD20 positive in at least 20% of the lymphoblasts. So those individuals getting rituximab did much better in terms of complete remission duration compared to a subsequent trial not using rituximab, and same was true of overall survival. So a few conclusions, I think, regarding the NCCN recommended regimens. Half were very asparaginase poor, and the other half were just poor. So not a lot of asparaginase was used. 1/2 promote myelotoxicity over lymphocytotoxicity, and that is a major difference between pediatric style protocols and more traditional adult protocols, and that may have bearing on outcomes. Half of them historically had used cranial radiation, but I would say now for the average patient it's established in both children and adults is not necessary. Age-related outcomes were evident. Those under age 30 did better than those over age 30. And we know from other information that I did not show that that group probably does better on pediatric-inspired regimens. What about the question of chemotherapy versus allogeneic transplant? Again, I made the argument yesterday that I don't really think it's clear that we should be routinely using allogeneic stem cell transplant in adults with ALL and use the risk-adapted mechanism to choose that instead. and that currently is our behavior. And there are unanswered questions. What about the intensity of asparagine depletion, and how do we contrast that with the risks of complications of the treatment going forward? I don't know that it's clear or clearly established across centers who should actually get allogeneic stem cell transplantation, and what about the use of new personalized targeted agents in the era of cryptic translocations? How is that going to change how we treat older adults with ALL, and it may change it dramatically. So I do advocate clinical trial enrollment whenever possible, and for, at least at UCSF, we're continuing to use a risk-adapted treatment scheme to make decisions about allogeneic transplant. Thank you.